for inviting me to give this very much a whirlwind tour of the experience that South Africa has had over the past 70 years. I think it was really nice to hear from Douglas that the analogies that exist between what's happening with HIV today and what has happened with tuberculosis for the last 70 years. So as Douglas mentioned, I think it's important just to reiterate that resistance in mycobacterium develops spontaneously and is present always if there is a big enough pool of bacteria in a person's lungs. And when one loses one drug, then there is an opportunity for subsequently gaining a resistance to another drug. And this led to a definition where the best drugs were lost, isoniazid and rifampicin, and leading to the definition of MDR, which is now one of the main surveillance measures used by the WHO to look at drug resistance in the world. And I think this picture from the latest report shows how in Southern Africa we have a fairly high prevalence of MDR, which is a major concern, and one wonders how it actually has developed. And when one looks at XDR, which is the newest kid on the block in terms of the monitoring of resistance. It's resistance to 4 of the best drugs available. And one knows that TB has a very limited repertoire. And if we look at South Africa, it's very obvious that we have an enormous problem with rates of over 500 XDR cases per annum. So one of the real worries about drug resistance in the world, and not only in Africa, here are the figures from Africa, is that cure is extremely difficult to achieve. And in most instances, only around 40% of our patients have successful treatment. The rest die or lost to follow-up or transferred out. So the green bars really represent this major limitation in being able to cure our patients. The rule sort of is that around, if we take 100 people, around 88 or 81 of them will get a diagnosis. Only 19 of those will get onto treatment, and around 9.5 will actually get cured. This is a tremendous dropout happening in the world, and implying that very few of our MDR cases worldwide are actually ever successfully treated. Oh, the figure has changed. I think the emphasis of this particular, there's the colors. Let's go back. I think the emphasis of this, and maybe just to highlight, is what is it costing national TB control programs in order to control drug resistance? The red bar indicates how much money is being spent, around 45% of the total budget to treat this very small proportion of the epidemic. I think that is one of the big stumbling blocks. It's consuming that funds that could be used better to treat patients with drug-susceptible TB. So how did this all happen in South Africa? And I think we have to go back, as Douglas did, go back to the very early papers. And we look back in 1950, and where it's being clearly said that we shouldn't be using drugs indiscriminately because it's creating resistance. The following sort of papers came out in the later 50s suggesting that resistance had a compromising effect on fitness of the pathogen, and therefore, if we treat drug-susceptible tuberculosis, resistance will disappear because they can't spread. That is clearly not the case when one looks at what is happening in the world. If we look just at this last little question about, and it was also brought up in the HIV talk by Douglas, this classification of acquired and primary resistance. I call it the blaming game, because when you get primary resistance, you were just unlucky. If you have acquired resistance, you were actually the problem. You created this problem by not taking your drugs. And so you got categorized. And most of the efforts in terms of TB control focused on the acquired group rather than on the primary group, because there was a risk because we knew that they had been treated before. So what happened? How do we address this? So in South Africa, in 2002, the guidelines came out for a new case, not knowing anything about resistance profile, treat them with the 4-drug regimen. And only if there's failure, do we do drug susceptibility testing. And I think that happens in many of the SADC countries today. If you were a retreatment case, then you got a drug susceptibility test, and then you went on to second-line treatment consisting of those 5 drugs. What was the consequence of doing this? So this is a study we're still putting the data together, but it's back in 2002 to 2004, and I'm sorry that the slide is not coming out clear here. But what I wanted to emphasize, that if you took 48 MDR cases and enrolled them into a standardized treatment program that was hospital-based, 25% of them got reinfected because of nosocomial transmission. Okay? And of that, 9 of the patients down here gained resistance due to this reinfection. The other remaining 75%, some of them, 36% of those gained, wrong place, dyslexia, gained resistance due to the treatment program. So clearly, by giving this regimen and putting patients together, we created a problem of amplifying resistance. What was the reason? Well, the surveillance that was done prior to 2002 didn't look at 2 of the drugs in the frontline regimen, the first-line regimen, ethambutol and pyrazinamide. They thought that there was no resistance in those 2 categories. In fact, when we looked at them, there is around 50% of all MDRs have resistance to pyrazinamide, and similarly for ethambutol. So in many instances, patients who had MDR, i.e. resistance to isoniazid and RIF, actually had MDR plus 2 other drugs. So when treatment came along, which was the second-line treatment, which is now in this box over here, and I hope that people can see it over there, you will see we were missing 2 drugs in this 5-drug regimen. So clearly that had a potential effect on amplifying resistance. Another factor that was not known until very recently was that isoniazid resistance was caused by a particular mutation which conferred cross-resistance to another one of that regimen, ethionamide. So in fact, many patients who were unlucky enough to have MDR with an INH-A promoter conferring isoniazid resistance and ethambutol and pyrazinamide were in fact only getting 2 drugs. The consequence is going to be amplification of resistance leading to XDR. And I want to show this very briefly, and we think this is, we have sort of labeled it as programmatic selection, because the program was a one-size-fits-all, and this led to this selective process. So if we look at this figure of South Africa, 3 provinces where there's been relatively good surveillance done. If we look at the bar graphs, this is the population structure of different genotypes of drug-susceptible TB. If we look at drug-resistant TB, we start to see a little bit of the blue color coming out, the purple color there, particular type of strain, and there's the same amount of yellow in Eastern Cape. As we come to MDR, we see this blue increasing here, roughly the same. Sorry, this is actually pre-XDR there. Let me just see. No. Yeah. We see that there is, in MDR, we're starting to see this yellow strain becoming selected, and the purple strain is continuing to be selected in KwaZulu-Natal. As we go to pre-XDR, 1 drug away from XDR, which was isoniazid RIF with fluoroquinolone and aminoglycoside, we can see how we are selecting very strongly for a particular set of genotypes. And we get the famous outbreak in KwaZulu-Natal of the XDR, which initiated this whole XDR surveillance in the world. If we look at the Eastern Cape, it's caused by 1 strain. It's just ongoing transmission. In the Western Cape, where I am, we see the yellow and the blue, clearly implying this movement of patients from the Eastern Cape to the Western Cape, bringing their XDRs with them, devastating the effect on the Western Cape's program. A major problem and a major concern, I think, worldwide. What are the treatment outcomes of XDR? Dismal. This paper published by Elise Peterson and headed by Ketan Deodar showed that after 5 years, 75% of the patients were dead. which is devastating. It really implies that this is a very, very difficult disease to treat. We're almost back to the era of pre-antibiotics. One of the big worries that came about from this study as well is that when we've tried all options, what do you do with the patient? Well, you send them home. And what that happens, then we wanted to look at how long were they able to survive in the community. And as you can see, some of them survive for many, many years with the potential to spread that disease to their families and to their contacts. So now an ongoing study to really understand whether these patients are infectious. So what are we doing now today? Well, the Department of Health last year brought out new guidelines. And we have to commend the Department of Health in South Africa for rolling out Gene Expert. I think South Africa consumes probably 50% of the world market of Gene Expert cartridges. It's actually quite amazing. And it is the fundamental basis of screening in this country, in South Africa. So when you have been diagnosed by a Gene Expert with a rifampicin-resistant form of tuberculosis as a marker for MDR, they want to put you onto MDR treatment immediately. Within 5 days, the guidelines say. Okay? And then we will do drug susceptibility testing, et cetera, et cetera. So we wanted to look at this, and this is unpublished data. We wanted to look, what was the consequence of doing this? Because I'm trying to show you throughout this talk that we've made these errors and we're continuing to make them. So what do we see here? We looked at all patients in the Western Cape that had a rifampicin-resistant isolate, 900 of them. If we jump down to the bottom, only 50% of those, just over 50%, actually got the second-line drug susceptibility testing done. So some patients were put onto treatment and no other further testing was ever done. The ones that did get a test, how long did it take to get that test? So we use this very fancy technology, and all of a sudden we have to go back to old-fashioned technology to do the second lines. It takes 2 months, according to all the data, and you can see the distributions there, clearly delaying any knowledge of what we are treating. So we have to think now that we are potentially treating with a regimen that is inadequate. So the next question was, is that in fact the case? So let's look at those isolates for what we had and try to understand what resistances were in them as they came into the diagnostic laboratory. I think the bottom line here, and I'm sorry I'm not able to sort of be cloned and show it on both sides, but the bottom line here is that 65% of all rifampicin-resistant cases had resistance to at least one of their second-line drugs. And we don't know it. I think that is a major issue. 12% were XDR, so they were getting a hopeless regimen. Sorry, a pre-XDR, also hopeless regimen, I think. And 7% had XDR, again, hopeless. We then thought maybe we should also look at some of the drugs that are not tested by the National Health Laboratory Service. And out of this, if we look at the quadrants, I'd really wanted to point out that 27% of the patients had actually 5 drugs that were effective. This is in a smaller group. 26% had 4 effective, and that's where the sort of cutoff comes. 47% had 3 or less. Clearly implying that we are putting these patients at risk of acquiring resistance. And there is some good data out there published last year showing that if you treat patients with a standardized regimen, when there's underlying resistance to the second-line drugs, they are going to become XDR. So the take-home message, treating blindly, which is what we're doing, leads to amplification of resistance. We need surveillance to guide policy. We really need to be able to pool all data, and I think it would be wonderful if one could pool data from the whole SADC region to try to understand what is the best strategies to address this. We have to realize the treatment with the current drugs of MDR is exceptionally poor, and there are some new drugs coming along, and hopefully those will make it into the regimens in the near future. Bedaquiline, delaminate, PA84, the 2 new, and linezolid, clofazimine, all coming into the regimen in the near future. As I mentioned, nearly half of the patients diagnosed with rifampicin resistance by expert, also have resistance to at least 2 other drugs. Very worrying. Culture-based diagnostics are pathetically slow. There are some tests in development for second-line drugs. Hain SL, line probe assay, is not the best test, but it's a good test and can give you an answer within 4 days, but we're not using. So these, we really need to try to change policy to try to implement these modern, rapid diagnostics to be able to ensure that patients are given the best options for treatment. I have to thank many of the colleagues who've done a lot of the work, the funders, and again, to the organizers for inviting me. Thank you very much.